Greetings. I'd like to spend a few minutes talking about diagnosis and epidemiology regarding mental disorders. And there certainly is some very useful information in your textbook, and I may have a little bit of overlap there, but that is fine. What I want to ask first, of course, is what is a mental disorder? And we kind of have these ideas. Is it a deviation from the norm, or is it a medical condition, a thought or behavioral disorder, a disorder of feelings, or a combination of these factors? And then we start thinking about, are certain behaviors in society considered mental disorders? The examples I like to use, because a lot of times people aren't quite sure where they fall, would be caffeine dependence or nicotine dependence, gambling addiction, sex addiction, physical abuse, and for example. Are those mental disorders? I'm not going to answer that question right now. I'm just going to kind of leave it. And then we get into, well, how do mental health professionals diagnose? Well, we have the Diagnostic and Statistical Manual of Mental Disorders, and the 5th edition, DSM-5, just came out. Brand new. It came out at the American Psychiatric Association meeting in May of 2013, and there are certainly some changes from the previous one, which is a real headache if you have a bunch of PowerPoints with DSM-4 TR on them. You have to, of course, update, and that's what I've done. This is only the desk reference. The actual DSM-5 is much larger and heavier and has many, many more pages. Basically, this is used to diagnose. It gives criteria, and so you could open to any page in here, and it would, say if a certain number of symptoms are present, then you would diagnose that person with that particular mental disorder, and then also you could rate it also as on a low to high type severity scale. And you can see some of the major areas that I point out from DSM-5, that neurodevelopmental disorders, schizophrenia spectrum and other psychotic disorders, bipolar and related disorders, depressive disorders, anxiety disorders, obsessive compulsive disorders, trauma and stressor related disorders, dissociative disorders, somatic disorders, and so on. Also of interest for us in this course, because we are looking at mental illness and the relationship to certain criminal activities, personality disorders and paraphilic disorders will be relevant, especially the antisocial personality disorder. And in paraphilic disorders, you would also start looking at the pedophilia and hebephilia type disorders and sadomasochistic disorders and the like. I wanted to just back up for a moment and mention that we've seen, we have a history of the DSM. The DSM-1 had 106 mental disorders, and then it jumped to 182 in DSM-2. Now, DSM-2 came out in 1968. I have DSM-2. It's very thin. See, I got this at a used bookstore. No, this wasn't the one that I was trained on. I was actually trained, and this is again the pocket manual of the DSM-3. So that tells you that several publications have been out since my training in mental health counseling, and 2, I'm old. This is the previous one, DSM-4 TR. See, look at that. It's heavy. Oh my gosh. You could, use this as a dumbbell for curling. And then the DSM-5, I have here the desk reference. And there's a lot of information online that goes over some of the changes that have taken place. And really our goal, what I did want to mention is that by the time the DSM 3 R hit, we had 292, or DSM-3 rather, disorders, and then DSM-4 and DSM-4-TR and DSM-5, that there are over 300. And so we've seen an increase in number of disorders. And there's still much debate on other disorders that were not included. We also have medical mimics of mental disorders that Hedaya discusses, just to mention that in diagnosing people, often it's extremely, not often, all the time, it's important to rule out medical mimics of mental disorders such as nutritional deficits or infectious diseases or hormonal imbalances or tumors or exposure to drugs or some types of environmental toxins. It's real important to rule those out. Years ago, I worked in a forensic mental health clinic. I shared an office with someone who did gerontology work, and he was very frustrated to get called at 3 o'clock in the morning from a assisted living facility saying that so-and-so is psychotic. And he'd say, well, get a urine screen, and they'd find out the person had the person had a urinary tract infection, and that seemed to lead them to show some of the symptoms of psychosis in that particular situation, and it was treated with antibiotics and they'd be fine. And so it's important to rule out these these medical disorders that may influence behavior. Also, I have in the PowerPoints the 5 purposes of diagnosis that Kirk and Cutchins in their earlier work mentioned. And so you might ask, well, why do we have this? Well, some of it's related to just regulating client flow. I mean, these are considered to be the mental disorders, and we assign diagnoses to clients. And then we are able to decide where to refer them or how to treat or where to treat. Should they be inpatient? Should they be outpatient, basically? Should they be seen by a specialist, and so on? And also protecting clients from harm. That we know there's certain mental disorders that are at higher risk that the person may harm themselves or others. Obviously, someone in a psychotic state or someone with dementia, and so they may need more intense intervention and supervision. Also acquiring fiscal resources. This is used for insurance purposes. That I remember before I got out of the field, managed care came along, and I had to fill out form after form after form after form, only to be told that the client had 5 sessions with me and I burned up 3 doing a diagnosis. What's wrong? I should have done a diagnosis in the first 20 minutes. I said, sorry, I'm very slow in diagnosing and cautious, and I like to take my time, and I like to do a lot of interviewing and some testing and so on. And I found out I just didn't work well in the managed care setting. I like to really, that some people diagnose first session and then start treating second. I just didn't work that way. Also rationalizing decision making. And so we know that if a person has a particular disorder, that there's acceptable ways to treat that disorder, and there's other ones. For example, I would never tell anyone that has a particular mental disorder to go home and read Dr. Phil books. I just wouldn't do that. To me, that would be unethical, irresponsible, and not helpful at all. I may find that I would refer someone thinking, okay, for example, I did not work with eating disorders. And so I knew that if I had a client come in or I did an interview and I thought maybe eating disorder was a major problem, I'd refer them to someone in the clinic that actually worked with eating disorders. And then advancing political agenda. That, believe it or not, there's politics involved in what becomes a disorder and what doesn't, and what the symptoms are. And you can see that some disorders are brought in or brought out based on basically vote. And this particular, this is kind of the secret DSM, where apparently there were kind of closed door meetings between the psychiatrists. There's a lot of debate about this. This is a hot debate issue. And so we're going to see a lot more merge from this. And of course, there's the theories of of mental disorders, and I just have a few that I list: biological, psychological, and sociological, to think about. This doesn't tell us how to treat. This doesn't tell us the causes of mental disorders. What it does is basically gives us the symptoms. And then I spend just a little bit of time on epidemiology, looking at the number or types or percentages of mental disorders in the population. I start historically with really one of the best epidemiological studies, the National Comorbidity Study, and it's been updated, and there's been more national comorbidity studies conducted, and this one really got us a good picture of the extent of mental disorders in society. One of the interesting features to look at is that comorbidity was quite common, and comorbidity means having more than one disorder, and that was relatively common. We also saw there were gender differences, that women had higher rates of depression, anxiety disorders, and men, for example, were more likely to have substance use disorders or antisocial personality disorder than women. We also see that age is related to mental disorders. And we see race and ethnicity, socioeconomic status, education, and urbanicity also related in a variety of ways. Also region. And then I break it down with the National Comorbidity Summary. When you look at lifetime and you look at 12-month percentages, you can see that almost half the population of the United States would be expected to have some type of mental disorder at some time in their lifetime. If we take kind of a snapshot, probably about close to a third has some type of mental disorder at any particular time. So you can see the different types. You have depression, alcohol dependence, social phobia, substance use disorder, anxiety, APD, which is antisocial personality disorder, and NAP is non-affective psychosis, which would basically be schizophrenia. And I broke down antisocial personality disorder in more detail from the study. So you can see that antisocial personality disorder is related to age, income, education, region, and gender. And then I have some other slides that show some of the earlier studies that show you basically what would be considered in some sense risk factors for mental disorders. But then the final slide I wanted to mention, and or before that, I also presented Loring and Powell's study that they published in 1988 that showed bias in diagnosis and assessment based on race and gender among psychiatrists. And we have to wonder, how far have we come since then? We have to look at replicated studies and see what we've done to address that. But that's something else to consider when we look at diagnosis and assessment and treatment, are factors that may influence decision making that are not necessarily related to the actual symptomology or the diagnosis. And then the last two slides really I think are important, even though they're older. This still holds, and that is mental illness and violence. You can see that certain disorders increase the risk, but a vast number of mental disorders do not increase the risk of violent behavior. And I think really Link and Stuve in 1995 said it best when they said gender, education, and age are better predictors of violence than mental illness or mental disorders, and mental disorders are not a major source of violence in society, and effective treatment would probably remove this small risk. So I think it's important to realize, because I don't want us to start labeling in a negative way, thinking that anyone diagnosed with some type of mental disorder is at risk for violence. That's not the case at all. There's a bunch of other factors that come into play, social factors and psychological factors, and also specific disorders. And that's what we're going to see when we get into your excellent textbook. And this wraps up this video. Thank you.